Yeah, yeah.
This is our third interactive live session, Learn from the Masters. We are privileged to have Dr. Barbara Parolini speaking on vitreoretinal interface disorders. We had two other classes on the same topic, on the same theme, Learn from the Masters, on pediatric retinal detachment by Dr. Sengul Ojde and on inverted ILM technique by Professor M.G. Outside. We are blessed to have Dr. Lalit Verma, who is a stalwart in vitreoretinal surgery worldwide. He is currently the president of All India Ophthalmology Society. He is the director of vitreoretinal services at Center for Sight in New Delhi, and he is a ex-consultant at All India Institute of Medical Sciences, New Delhi. He is in multiple leadership roles in national level and international level. Thank you, sir, for joining us. We have Shobhit Chawla, sir, who is a past president of Vitreoretinal Society of India. He is the director of Prakash Netra Kendra, Lucknow. Thank you, sir. We have Dr. Vivek Dave. He is clinician scientist and prolific vitreoretinal surgeon at LV Prasad Eye Institute, Hyderabad. He is also adjunct assistant professor of ophthalmology at Rochester University, USA. Thank you, sir. And we have Dr. Atul Dhawan, who has played pivotal role in arranging. Thank you, sir. And now we have Dr. Barbara Parolini, who is a stalwart in vitreoretinal surgery. It is a pleasure to see her surgeries. She is a key opinion leader, clinician, academician, and researcher. She has also she has a website for new vitreoretinal surgeons with excellent academic content, which is
हमारा इसमें ये हाँ अच्छा कुछ तो ऐसा करिए हाँ ये
I think we'll start now.
So I will share my screen.
Yes, ma'am.
Okay. First of all, thank you all for giving me this opportunity. I'm extremely grateful to be here with you, and I really am not here to give you guidelines. I'm here to share my thoughts on the topic and what I read in the literature and what comes out from my daily experiences. So I will be very happy just to share with you what I do and what I think on this subject, which is extremely interesting because this is what we encounter every day in our practice. So the management of vitreoretinal interface disorder. I want to especially thank my orthoptist, Veronica, that really helped me a lot preparing this talk and in everyday life. So the question is what to do and when to do it. And let's start from some historical thoughts. Donald Gast has seen everything. He, in 1975, had seen the lamellar hole and defined it as derived from unroofed CME. So he had this intuition of loss of tissue. And he also described the pseudo hole as a contraction of an epiretinal membrane, which was simulating a full thickness macular hole. And in that too, he had the intuition of a contraction problem. In 2006, Whitkin described with OCT 2 different epiretinal membrane associated with lamellar macular hole. So there was a huge gap in the history of this disorder from Gast to Whitkin, actually, because nobody had really described and deal with lamellar macular hole until that time, and it was OCT that helped. So he first saw the 2 different epiretinal formation on top of lamellar macular hole. And in 2011, I actually described these different lamellar macular hole associated to two different epiretinal membrane. And I performed the first histopathological demonstration and analysis of the two different membranes. In 2013, there was this international vitreoretinal traction study who gave definition of VMT, lamellar macular hole, and pseudo hole based on OCT. In 2017, Govetto differentiated differential and tractional lamellar macular hole, although they had been described, but he was good in offering nice images to easily remember the two holes. Very important in 2019, the OCT-based consensus on the definition, on the nomenclature of all these disorders. And this is the one that I will use today. So Gas used a slit lamp, and it was such a genius in doing so. All the other studies are based on OCT, and that is why the definition, the nomenclature, and the knowledge on the vitreoretinal interface disorder has changed along with the improvements in the technology. I care to highlight that what I did was based on surgical observation, and then it was developed with OCT and histology, but I will show you more about my study in a few minutes. So what about definition? Let's all use the OCT-based consensus definition, not just of lamellar macular hole, but you will see all the other manifestation. So we will speak about epiretinal membrane, epiretinal foveoschisis, lamellar macular hole, macular pseudo hole, and vitromacular traction. They all have in common a disruption of the fovea. They cannot be well described with autofluorescence because, with the exception of the epiretinal membrane, they all show a hyperautofluorescence with the blue autofluorescence. So OCT is really the key tool in the diagnosis and differentiation of these disorders. The epiretinal membrane is a thin, irregular, and hyperreflective layer on top of the internal limiting membrane. It shows signs of wrinkling very often, and there are spaces between the epiretinal membrane and the internal limiting membrane. These are the main characteristics. The epiretinal membrane with the foveoschisis is basically an epiretinal membrane that has associated a foveoschisis at the level of the Henle fiber layers. There are minor criteria that could be or not be present, like microcystic spaces in the inner layers, retinal thickening, and wrinkling. Very important is to highlight that in the fovea, there is displacement of tissue, but not tissue loss. And in order to know exactly what we are talking about, the foveoschisis happens in the layers that I highlighted with the red lines, between the outer nuclear layer and the outer plexiform layer, or in what has been described as Henle fiber layers, which is made of axons of the photoreceptors. A macular pseudo hole is again an epiretinal membrane, the thin tractional epiretinal membrane, which is foveal center sparing. It means basically that there is a hole inside the epiretinal membrane, and it has also retinal thickening and verticalized steepened foveal profile. Even in this case, we might find microcystic spaces in the inner retina and near normal foveal thickness, very important. The vitromacular traction can be divided in grade 1, incomplete cortical vitreous separation with foveal attachment, grade 2, intraretinal cyst or cleft, grade 3, it's like grade 2, but with foveal detachment. This one is very important, epiretinal proliferation, shortening ERP. So it is referred to the thick layer in an average 40 to 50 micron thick, homogeneous isoreflective and not hyperreflective. It is epiretinal material on top of the internal limiting membrane. It shows a full contact without spaces to the ILM. It is often covered by a hyperreflective line. This is exactly the tissue that had been described by Witkin in 2006 as a thick membrane, the one that I described in 2011 as dense membrane, the same that has been described by Pang as lamellar hole epiretinal proliferation, because he thought it was only linked to lamellar hole, but instead it has been found in other situations like macular hole, uveitis, Pucker. So it is more correct to define it epiretinal proliferation and not LHEP. And proliferation seems to be very appropriate because it seems to increase in time. So focusing on lamellar macular hole, we should define lamellar macular hole only the irregular foveal contours with nonlinear shape of the foveal pit, with the foveal cavity and undermined edges, meaning erosion, tissue loss that can have associated a pseudoperculum, defining the foveal loss, foveal tissue loss, thinning of the foveal end in the center, and also the epiretinal proliferation that I just described, with the foveal bump, which is the bulge in the center of the cavity, and disruption of the outer retina to the line of photoreceptors. So this is a very different entity that compromise vision more significantly. So I would like to mention the work that I had done in the past, because I like the idea of telling you how it started. It all started with the surgical observation. I was peeling a membrane in a lamellar macular hole, and at the time I used to do surgery on all of them, and I didn't know the difference. So I was peeling this yellow material, very fluffy, very inconsistent, and I was telling myself, what is this? Am I peeling the fovea itself? And then I realized I was not peeling the fovea. It was not a degenerated fovea, because afterwards I could stain the internal limiting membrane and peel the internal limiting membrane. So with that observation, the whole idea started to analyze those membranes and see the difference between the regular epiretinal tractional membrane and this dense fluffy material. So I called Ricarda Schumann and Christos Aritoglu in Germany, because they were doing a lot of work in analyzing ERM and ILM with staining, without staining. If you remember, they were the one that did all the work on Indocyanine green, looking for the toxicity of the dye. So I called them and I told them about my surgical observation, and we designed this prospective study. So this is, yes, to acknowledge my co-authors. And these were the case series made almost half and half of dense membrane and tractional membrane lamellar holes. So we described the OCT criteria, and then we did the immunohistochemistry to study basically the composition of the cells. And then we did a transmission electron microscopy to study the composition of collagen inside the tissue, inside the internal limiting membrane and inside the epiretinal tissue that I was giving them. So in summary, what we concluded is that the tractional epiretinal membrane was the thin contractile epiretinal membrane that we all were used to peel, very rich in alpha smooth muscle cell, so with strong contractile property, composed with glial cell and hyalucyte 2, with a small amount of collagen. Instead, the dense membrane was then again a dense, thick epiretinal tissue, very rich in collagen, with a small amount of cells, not alpha smooth muscle, but only glial and hyalucyte. They could both be peeled. However, I have seen a high risk of inducing iatrogenic full thickness macular hole by peeling the whole tissue. And I had in that study 16% risk of inducing full thickness macular hole. So in real life, when we do OCT, we can also observe mixed cases. Look at this one. What is this? Is it a lamellar macular hole because it has the cavity, because it's very deep, or it is an epiretinal membrane foveoschisis because you can see the schisis inside the Henle fiber layer, or is it a pseudo hole because it has verticalized edges and it seems just an epiretinal membrane with a hole? Or look at this one. Is it more appropriate to define this as a lamellar macular hole because it has disruption of the outer retina? Or is it a macular pseudo hole because it has verticalized edges and an epiretinal membrane? And this one too, I mean, it's not easy to fit them in just one definition. This is what happens in real life, but it's good to have a guidelines on nomenclature because it leads you to better know what to do and when to do. So how to treat and when to treat epiretinal membrane. Let's say what we find in literature. We find a good consensus on operating the epiretinal membrane. And I want to cite this wonderful study that my colleagues Sengül Özdek, together with the Turkish colleagues, published a few years ago. So they collected 634 eyes and they followed them up for 2 years, and they divided the whole group in 4 types of epiretinal manifestation, allow me to call them like that. They did not follow the OCT consensus nomenclature, but we can find in there the diffuse type, the foveal herniation type here in A and C, which are basically the most frequent epiretinal membrane that we encounter. And they included what they call the pseudo hole. Actually, if we follow the consensus nomenclature, this should be an epiretinal membrane with foveoschisis type. But I think they can be associated because they have the same indication to surgery and the same results. 12% of the cases were instead vitreomacular traction, and they inserted all this type in the whole group as well. What did they find? So the best preoperative visual acuity was in the diffuse epiretinal membrane. Actually, sorry, the best was in the one associated to foveoschisis, and then the diffuse, and then the vitreomacular traction, and the worst preoperative visual acuity was in the herniating retina through the epiretinal membrane. Which were the prognostic factor to reach a final visual acuity of 2025? So the question was, what should we do? Which cases should we operate to reach a great functional result with surgery? And surgery consisted in peeling of the membranes. Well, they said that a preoperative better vision was a good prognostic factor to reach a high postoperative vision. And the integrity of the external retina still, again, was a good prognostic factor. Sorry, let me go back. The peeling of the ILM seemed to be a negative factor when they studied the 6 months and 12 months point, but not confirmed at 2 years. So this was uncertain. The smaller gain was for the epiretinal membrane with the foveoschisis or pseudo hole. The highest gain in vision was in the herniating type. But I think it's because the pseudo-hole or foveoschisis type was starting with the highest preoperative vision. So the gain was less because they started high. And the opposite was true for the herniating type, which was starting with a very bad preoperative vision, but showed a huge gain. So this is extremely interesting. What about anatomical restoration? So to obtain finally postoperatively a fairly normal retina, what should we look at? Again, it depending on the type of epiretinal membrane, where a pseudo-hole type did better and herniation did worse. And again, everything was linked to the status of the external retina preoperatively. What about techniques? In the end, after peeling the epiretinal membrane, the peeling of ILM was controversial, potentially harmful in some cases, but they were not able to reach clinical significance on that topic. So it's still an open question. The presence or absence of tamponade at the end of surgery was not crucial to the final results. And look at the complication. They ended up with 1% full thickness holes. And I specifically asked to Sengul, because this is not written in the paper, if they had a higher concentration of holes in the VMT group, but that was not the case. Only one hole was in the VMT subgroup. They had 0.6% retinal detachment and 2.4% breaks that were treated. So in summary, from the literature, the message that comes is treatment is advised for epiretinal membrane, pseudo-hole and VMT. And to reach a good final acuity, we should operate when preoperative vision is around 20/40 or lower. And the better is the external retina preoperatively, the better will be the restoration postoperatively. So the message is that we should not wait too much. I want to show you my most extreme case of epiretinal membrane surgery. It was a male, 58 years of age. Best corrected visual acuity preoperatively was 10/10, 20/20, call it as you like, in both eyes. But he had metamorphopsia and micropsia in one eye. It gets worse. He was complaining not to be able to operate. So you know now that he's a surgeon, but worst of all, he was a vitreoretinal surgeon, a colleague of mine here in Italy, which was telling me, I know the case, I know I'm 20/20 if you measure my sight vision, but I cannot work. And even in microperimetry, he just showed a decrease in sensitivity in the left eye. But the most bothering symptom was the metamorphopsia and micropsia when using the microscope. So this was his retina, the SLO image, the thickness map, and I will show you the surgery. Usually I do either 25 or 23G, core vitrectomy first, staining. I use a blue staining, which is called double dyne, which is very useful for epiretinal and inner limiting membrane staining. I peel with forceps. I do a second staining. Most of the time I still peel the ILM, and I extend the peeling to the arcades when I peel epiretinal membranes problem, because I want to remove the whole traction. I want to avoid secondary tangential traction remaining and tissue ectopia. Then, of course, I check the periphery and I treat what needs to be treated. And I inject a bubble of air, mostly for the hypotonia issue and not for the membrane as well, not for the macula. I like to care to tell you that I don't like to use injection of staining. I like to use the term pouring the staining, because I want to stay very anterior when I pour the staining to avoid the subretinal injection. So one tip is stay anterior and just pour like you're pouring a glass of wine, and don't inject abruptly. when using the staining, whatever staining you're using, whatever substance you are allowing inside the eye. So this is actually the surgery of our vitreoretinal colleague. I have the luck of using the intraoperative OCT, which I mostly use to check what I do in the fovea. I'm always very scared of inducing an unroof of the fovea. And here you can see very well what happens during the peeling. The fovea remains intact. And when you peel I was only peeling the epiretinal membrane, but at the same time, I was pulling the internal limiting membrane, and you see it very well. So sometimes you cannot control the peeling of the internal limiting membrane. That's my point. Okay, so in the end, I see that with the negative staining, I don't have much ILM left. And this is to show you how much I enlarge the peeling only in epiretinal membrane as opposite as a macular hole, where I try to save as much ILM as I can for possible reopening. Here I want to enlarge the peeling in order to remove all the traction. So this was the result on top of pre-op, on the bottom post-op. And I really wanted to show you this because you know that the usual final appearance post-operatively is not the restoration of the foveal depression. Usually we still have a very thick retina that remains forever, although the vision improves. Instead, this was the case that I operated with the highest visual acuity, as you can imagine, preoperatively. I usually don't do that. And, but I was, it was striking to me how the fovea was restored postoperatively. These are other examples, just to show you the response of the tissue. Look at the OCT when we do the peeling, what's the response of the tissue intraoperatively. So in summary, my advice on when to treat epiretinal membrane, and I associate to that epiretinal membrane with foveoschisis and pseudohole. I advise treatment when best corrected visual acuity tends to reach 0.6 decimal or lower, but I advise to act sooner if there is metamorphopsia or micropsia, because as you well know, they are much more difficult to improve after surgery. What about vitreomacular traction? Well, I do vitrectomy just with cortex removal. That ILM peeling here is debatable because there is risk of inducing a full thickness macular hole, but the topic is really open for more data collection. This is just an example. I want to show you how I prefer to see what I'm doing compared to other techniques. I prefer to look in the eye, the vitreomacular traction, and peel it with the vitrectomy probe. I go very, very, very slowly, and I try to go around it first. I use a very low aspiration value. Usually, you know, the core vitrectomy is I perform it with a 400 millimeter of mercury vacuum. Here, I probably am using no more than 100. And then I use the intraoperative OCT to check what I'm doing. You will see at high magnification now, after more staining of the vitreous. Here you will see I am using a new staining that was provided to me from an Italian company. It contains lutein, but it works like a triamcinolone. And you will see the effect of this maneuver. The very last peeling was performed, but this is cortex, only vitreous cortex. And you will see with the intraoperative OCT the effect of the release of traction, the vitreofoveal traction, very, very slowly with the forceps. And at that point, surgery is done. Okay, so this is one of the case As you see, I tend to follow the patient for a long time. Usually I never advise a surgery at the first consultation. I check this patient in June, and then I rechecked her in September. And then from September 5, we scheduled surgery because it was very bad. And then I saw her again on September 16. And this is the post-operative result. On top is a few days after surgery, and now is more than 1 month after surgery. On the bottom, you see the good restoration of the foveal contour. So for vitreomacular attraction, we have options to vitrectomy. What about ochriplasmin? This is the latest paper that I found on the subject. And to me, it's not convincing. It's not giving us real results. It's giving us how the profile of the fovea changes with the injection of ochriplasmin. My experience in the past was not so convincing. I used the ochriplasmin, especially in one patient that had vitreomacular attraction in both eyes. I injected in one eye ochriplasmin and in the other only BSS. I had not done the paracentesis because it was my first case and I just injected the substances. I had, when I retracted the needle, I had some vitreous incarceration in site of the injection in both eyes, and I had a release of vitreomacular attraction in both eyes. So I thought that it was not the chemical action, but the mechanical action that induced the release of VMT. And in parallel, I was fearing possible side effects of the ochriplasmin on other tissues of the eye. So I stopped doing, and I still am not using it, and I will wait for more research and more data. What about gas injection? It could be a good idea. So if we inject something in the eye, we induce the release of the vitreous abruptly from the macula. But even in this study, as you can see, you can end up with the rhegmatogenous lesion and with the full thickness macular hole. And so at that point, I prefer to have the control of what I'm doing through vitrectomy than by injecting something without knowing the effect. So my advice is to use vitrectomy. As I said at the beginning, I'm not here to give guidelines. I'm here to give you my thoughts, which is the collection of experience in my daily life and from what I hear from the literature. So in summary, from vitreomacular attraction, I advise the treatment again when vision is becoming symptomatic, and again sooner if there is a strong metamorphopsia. But here the point is different. It's not exactly as in epiretinal membrane. This patient has a focal deformation of the fovea, and they might refer a central scotoma if the fovea is detached. And I tend to wait more than what I wait with the epiretinal membrane, because first of all, I wait for possible spontaneous resolution, and I want the patient to really become conscious of his condition before going to surgery. What about lamellar macular hole? Should we operate this entity or not? Well, the problem with the lamellar macular hole and epiretinal proliferation or dense membrane, call it as you like, is the risk of inducing iatrogenic full thickness macular hole while operating and due to the peeling. This complication was described by Whitkin in 2006, and then I described it in 2011, and then many others after me. So the thoughts on whether or not to do surgery on these cases is very controversial, also because they tend to be a very slowly progressive disease. However, I think a possible solution is to avoid complete peeling and to switch to tissue embedding. What do I mean with that? I mean that instead of completely removing the epiretinal tissue, the thick yellow tissue that does not seem to be an epiretinal membrane, we should leave it inside the hole and reconstruct the foveal profile. It's been done. It's been published also by a colleague of mine with the technique of double inverted flap, meaning that I'm sorry, I'm not in the paper, although we used to do these things together. We've been working together for all our life. Basically, the technique consists in peeling the yellow tissue and leaving a flap inside, then peeling the internal limiting membrane and leave a flap of internal limiting membrane inside. So with this video, with again, look at the OCT mostly, you will see the immediate effect of lifting the epiretinal tissue. You almost see how you are reconstructing the foveal contour by the minute. You basically are solving the case intraoperatively. And in this, the use of the intraoperative OCT is really essential to allow you to understand the tissue response to your maneuver. So this is the lifting of epiretinal tissue. I will go a little quickly for sake of time. And then what do I do? Since I lift a huge amount of tissue, I decided to trim the tissue with a vitrectomy probe with a very low aspiration value, like 20 millimeter of vacuum, no more. And then I stained looking for the internal limiting membrane. And then I will go quickly to ILM peeling, which is lifted all around 360. So here you see the thick epiretinal tissue at the very edge of the hole and all around a layer of internal limiting membrane surrounding the epiretinal proliferation. I'm moving forward. So this is the fluid air exchange. I tend to stain again under air because I want to make sure of where my tissue is at the end of surgery. So on the left, you see the blue staining of the tissue remaining on top of the hole. And on the right, with intraoperative OCT, you see how the hole is completely closed at the end of surgery. Here. Okay. So this was just to show you a schematic of the technique, but I think you got this, so I'm moving quickly. And this was taken from the study which was published that compared the double flap technique with simple ILM flap. Again, trimming. And this was an example of post-op result. So this was to show that the group with the double flap technique gain in average 2 lines in vision, much more than the other group. And sorry, these are just other example. It works even in myopic eyes. See, pre and post. I placed also macular buckle, but that's not the point. It was to show you the contour of the fovea. And in that case, they concluded in the study on the double flap technique, they concluded that it was better to intervene soon or sooner than usual because there was a good correlation with the integrity of the external limiting membrane preoperatively and postoperatively. So You will find in the literature many papers against the surgery of this type of holes. They are stating that visual acuity does not improve significantly, then that there is the risk of inducing iatrogenic full thickness macular hole, and that there is no change in the foveal structure. However, these are papers that perform classic peeling. They remove the whole thing, and so that's why it happens. But the embedding technique has been proposed not just by us, but by others as well, and they all report a good restoration of vision and anatomy without the problem of inducing full thickness macular hole. So some issues are, of course, open. Is the ILM peeling necessary? Maybe not. Is the trimming necessary? And to what extent? We don't know. So I want to report another experience of treatment of sublamellar macular hole with micropulse laser. Look at this on the left, a patient coming with low vision, central scotoma, and since she had subretinal fluid, and I'm having a very good experience since 2016 with micropulse laser, I propose to reabsorb the fluid with that technique. And on the right, you see actually reabsorption of the fluid with partial restoration of function and anatomy, just 1 month, and then again 1 month later after the treatment. But I proposed this only because there was this subretinal fluid presence, and I know already that micropulse laser is really effective on any type of subretinal fluid. This is another example. This is another case. You see the follow-up from left to right with a complete reabsorption of the subretinal fluid. And if the fovea is reattached, the point is that the patient gains vision, so you don't have to go to surgery so quickly. You can, anyhow, I want to present you this technique as an alternative for patient that you don't want to take to surgery. This is a highlight on left and right of the result of just 1 session of micropulse laser. So one weakness of the surgery for all this interface disorder is that the spontaneous improvement has been described with all of them. This large study described what happens in the natural history of vitreomacular traction, and they reported 21.4% spontaneous resolution, which actually varies among the grades. So in grade 1, we have only 4.1%. In grade 2, we have 21.4% was the rate of spontaneous resolution. However, in the natural history, of course, they also observed a 7.7% of negative evolution to either lamellar or full thickness macular hole. And the negative evolution was different based on the initial grade of pathology. So in grade 1, only 4% evolved negatively, in grade 2, 6.8%, and in grade 3, 23.8%. This is a patient of mine. These are 2 different patients on the left and on the right. I want to show you basically the same appearance at baseline with opposite outcomes. So the patient on the left is a female of 50 years of age with 0.7 vision. On the right, a female of 82 years of age with a lower vision, 0.5. I checked them doing nothing, and the one on the left had a spontaneous improvement, and the one on the right ended up in a full thickness macular hole. And if you focus on that patient, I want to show you that the other eye had a history of evolution from DMT to full thickness macular hole to closure of hole, because I had operated her at the time. And so now that patient is had a closed hole, but interestingly enough, she had the same history in both eyes. look at this patient. In October 2020, he had an almost complete full thickness macular hole with 0.5 vision. He's a high myopic eye. 1 month later, he has a spontaneous closure that completed 1 month later with good restoration in vision. He comes back in February 2022, so more than 1 year later, with a deep lamellar macular hole. And I checked him a few weeks ago in September. He has a deepening of the lamellar macular hole. So the patient is asking me now, doctor, what should we do? Should we wait for more spontaneous evolution, or is this a sign that I'm going to a full thickness macular hole? And so I think I will suggest surgery, but it's not an easy decision, as you can imagine. And this is another striking evolution. This patient had a retinal detachment operated in 2017 with very good result and good restoration in vision. Then he comes back in 2019 with the full thickness macular hole. Interesting, he had no vitreous. He had been operated with vitrectomy. So he developed a macular hole almost 2 years later with no apparent cause. So I proposed the surgery. I give him topical steroids, and only 2 months later, he had a spontaneous improvement. So I don't see the patient for a while. He was happy, but then he comes back this year in January. And what happened? It doesn't seem the same retina. He had this bad appearance degenerated with tissue loss and a deep lamellar macular hole. I just checked him, and in August, he was still the same. And interestingly, I have observed a worsening in the visual field. He had an increase in IOP, and this was one of the reasons why I did not advise surgery when he came back with the lamellar macular hole. And I'm wondering, and this is another open question for you too, whether there is an association between the loss of fibers due to the increase in the IOP and the loss of tissue in the fovea. It is reported that also lamellar macular hole with dense membrane can improve spontaneously. So if you look at the follow-up of this patient that has been recently published, it seems like we did the surgery with the embedding technique. It looks like the post-op that I have been showing you earlier. However, if you check, the external retina is not present. Unfortunately, he had an anatomical restoration, but not functional restoration, because the external limiting membrane is not complete. So I'm wondering whether we should do that through surgery at an earlier stage. Most of them are bilateral. So I'm thinking whether this situation are different manifestation of the same condition. These are just some examples, but I'm sure you find them in your daily life as well. If you have this issue in one eye, probably they have a similar issue in the other. In this case, a deep lamellar macular hole and a shallow lamellar macular hole on the other eye. Again, one eye and the other eye. This patient in the right eye has a epiretinal membrane with foveoschisis, and in the other eye, he has been operated for full thickness macular hole. So I touched the nomenclature, I touched the treatment divided by topic, I touched the item of spontaneous resolution, the bilaterality of this condition, and I want to conclude by saying that I think we should operate vitreoretinal interface disorder. I think we should aim to the best functional result, which is linked to the foveal integrity preoperatively. We should know that spontaneous improvement is possible, but it might not lead to favorable anatomical design. So I think that epiretinal membrane together with pseudo-hole or epiretinal membrane linked to foveal cases, should be treated with epiretinal membrane peeling when vision reaches 0.6 or sooner in case of metamorphopsia. That vitreomacular traction, we should wait maybe even up to 1 year after the initial symptoms for spontaneous improvement, but watching the patient carefully and operate only by removing the vitreous if vision or anatomy tends to worsen after the first 6 months, especially if the outer retina is damaged, and treat with the cortex removal if there is a lamellar macular hole. So I want to challenge you now, and because by preparing this talk, you gave me the opportunity to collect my thought, to see what's missing and what we have to do for the next future. I think there are many open questions. We should find out what is the real role of ILM peeling in this condition. The role of ILM peeling in particularly in treating VMT, should we peel the ILM as well if there is just a vitreomacular traction, maybe by leaving an inverted flap to avoid iatrogenic macular hole? Which are the changes in microperimetry when we treat this condition? What is the role of micropulse laser in a niche when there is a foveal detachment? About vitreomacular traction, what's the real rate of spontaneous improvement versus the rate of iatrogenic full thickness macular hole in a long follow-up, so we know better if we should really operate or just wait? What is the role of surgery versus natural history on metamorphopsia, micropsia, aniseikonia that might bother patients even more than vision loss? What is the role of epiretinal membrane embedding in lamellar macular hole in a long-term follow-up? And what about the bilaterality of this condition, which you have more data on that? About also the rate of vitreoretinal interface disorder in presence, but also in absence of vitreous, because we have seen that we can have this condition even in patient that has already been vitrectomized. So maybe it's not just vitreous, it could be retina, it could be loss of optic fibers or something that we don't know. Let's do it together. And with this, I thank you.
Great Dr. Parolini, and
Yes.
it's one of the best talk I have ever attended in my career.
Thank you. I was very worried giving this talk, telling the truth, because there are many controversial issues, and it's difficult to have a clear thinking on this topic.
I would like to ask Lalit sir, what's his take about surgery in the case of the ERM and the VMTS?
Yeah, thank you, Atul, for having me here. And I must also congratulate Barbara, one of the finest talk on interface disorders in recent times, and a lot of clarification, a lot of finish she had in delivering this talk. As far as this question is concerned, honestly, I'm more scared to operate a patient of VMT rather than an ERM, primarily because of, put it down that I'll ask Barbara, a patient who has VMT with tenting of the, macula, I would, normally go around and do a foveal sparing separation of cortex also. You see, I would not dare to pull the cortex at lowest possible suction also. So what I do is I separate the vitreous with the help of triamcinolone, but have a small stump at the level of fovea. And this small stump is kept hanging till the end, because if I pull it, then there is an issue of phytogenesis. And second is that I generally do not, and have been practicing this for a very long time, that generally do not take out the ILM in patients of ERM. it comes easily, because a lot of these patients of ERM have adhesions with ILM. So a lot of times it may come once you are peeling the ERM, but necessarily I will not, push. I will try. If it comes easily, it's okay, but I will not keep trying and trying, because it induces iatrogenic damage to the nerve fiber layer also. And you are right by saying that, even OCT studies have shown, ganglion cell affection. What to microperimetry you have rightly pointed out. But even if you do OCT in patients where you have peeled ILM and where you have spared ILM in ERM surgeries, the changes have been shown. So Atul, my answer to this is that I wait for patient to virtually ask for surgery rather than my pushing him for surgery. Patient has to ask for surgery. He has to be disturbed with the metamorphopsia. Like she showed the excellent example of VR surgeon, where vision was very good, excellent normal vision, but patient had metamorphopsia. So I think metamorphopsia is more important rather than the visual acuity. So patient has to ask for it. Patient has to virtually beg for it, that he is disturbed in his day-to-day life, and his day-to-day life is hampered by metamorphopsia. Then you do surgery, rather than we motivating the patient. I do not proactively motivate any patient of VMT to undergo. He has to ask for it. No, Barbara?
Yes, especially in
Dr.
VM.
Dr. Parolini, I want to ask the question related to the same patient. In how many months the metamorphopsia improved in that VR surgeon?
Very quickly. I was surprised, like a couple of months, he had a quick improvement. This is the only patient that I operated with that good visual acuity preoperatively. And you can imagine how fair discussion we had preoperatively. We were speaking the same language, and he asked for it. And I said, I'm coming to you. I want you to do this surgery. I'm really in trouble when doing
our metamorphopsia improvement is much years also, but the functional, improvement of metamorphopsia generally occurs within a few weeks. And patient is the happiest man because you have taken care of his symptoms.
Yes. Instead, I am used to other patients where maybe I operate at a later stage, they regain vision, but the metamorphopsia is very hard to remove, and they always complain about that. That's why I'm changing my timing of surgery. And if they have metamorphopsia, I tend to intervene much sooner. And also, I mentioned to say just one tip in the surgery of VMT. When I enter with the vitrectomy probe, I keep even the infusion very low at the minimum, because maybe sometimes just infusion can abruptly detach the vitreous. So it's a very gentle and slow surgery compared to other situations.
And pharmacology.
Dr. Vivek. Yes, sir.
Pharmacology vitreolysis is actually out, and ocriplasmin came with a bang and went with the equal amount of bang, because not only it's expensive, but the surgical success rate is dismissal compared to a nearly 95% or more success rate which we achieve with MIVS. So standard of care in all these disorders has to be MIVS rather than. And like Barbara was saying, any injection, in fact, in the vitreous cavity can induce PVD. So therefore, pharmacological usage of ocriplasmin should not be encouraged, and not a good proposition.
Dr. Vivek want to ask something, Dr. Parolini. Dr. Vivek, yes. Please continue.
Thank you, Dr. Dhawan. I hope I am audible. Good evening, Dr. Parolini. An excellent talk, wonderful constellation of OCTs and case scenarios. I wanted your opinion on a particular scenario that every now and then we do see here in India, in the sense if we compare the Western literature to our literature or our experience, our macular holes tend to be larger. So seeing a macular hole more than 400 microns is not uncommon. So if you go by the Western guideline, almost every second or every macular hole for us would be a candidate where an inverted ILM peel, might be technically used. Now, once in a while, we see cases that have an epiretinal membrane along with one such relatively large macular hole. So when you start off with your surgery, you go ahead, you peel the ERM, and as you showed in one of those cases with the intraoperative OCT, the ILM often tends to come out with, or at least the most of the ILM tends to come out with your ERM. And then when you go in and peel again, you only have small islands or maybe tags of ILM left behind. Now you have a large hole where technically you would have liked to do an inverted ILM peel, but there is no ILM left there. So in such a situation, would you recommend actually putting in a free graft, or would you recommend just leaving it as it is? Have you come across this situation in your practice?
Okay, so first of all, I care to tell you that I avoided the topic of full thickness macular hole because I was specifically requested to speak about epiretinal topics and lamellar hole. But this is a very important question. In cases like this, most of the time you have an epiretinal membrane which has the thick appearance. In fact, I really think, as it's written in the literature, that the thick membrane is the result of a degenerative process of the fovea that opens and split the fovea in lamellar or full thickness macular hole. What I tend to do to avoid that is that I don't proceed with the full peeling. I go very slowly. And you remember I said that with epiretinal condition, I do a very large peeling to release the traction, but with holes, I do a small area of peeling because I try to preserve as much ILM as I can. So I peel only, let's say, 1 disc diameter large area of around the hole. I peel 360 and I keep all the tissue for possible stuffing maneuver, because the more the more holes I operate, the more I think that stuffing is the key. So let's say that in any case, I'm losing what I'm peeling and I don't have any tissue left. I would go first for free ILM, because I think it's there, it's very easy to peel. And if I have not enlarged too much within the arcade, I will find more ILM. And in cases where I don't find ILM, I would go for retina. Those are the options, but that would be an extreme decision. I think that in a primary macular hole, we should use what we have to cover the hole.
So you would say that the peeled ERM itself can possibly be, stuffed in the macular hole in such.
Yeah, let's say I'm not speaking for all holes. I'm speaking about you specifically mention very large holes with epiretinal tissue that very often might be the thick yellowish fluffy tissue, which is a degenerative tissue. In those cases, you should consider to stuff the hole with everything you have. But if you can do it with just ILM, of course, that is, our routine, and but we are not speaking about that now.
Thank you so much.
Shobhit sir, want to share some experience? Shobhit sir?
Yes. First of all, congratulations to Dr. Barbara on a very lovely talk. And most of the cases we encounter here, like Vivek said, I feel many of them are a continuum of the same pathology. You have a VMT with ERM. Rarely you might have the thick, fluffy ERM, as Barbara pointed out, with even VMT, so that's rare. It's mostly seen more commonly with macular holes, or in our setup, or with lamellar macular holes. And coming back to two things which I would like to point. One is what even Lalit says and what even Dr. Barbara stressed is the patient symptoms, and not to jump into surgery in any of these disorders, but to follow it up with periods of 4 to 6 months as is specific to that particular case. And once you have made a decision of surgery, if I'm doing a VMT case, I always like to reinforce my fovea with an inverted flap after having trimmed the vitreous with a low pressure vitreous surgery, leaving a small stump. I like to take the ILM and reinforce the fovea because I dread the chances of developing a macular hole. If I encounter epimacular proliferation and the hole is large, I use that instead of the ILM to flap and stuff the hole, which I feel serves the same purpose in my experience. And these were just a few points I wanted to point out. Thank you.
One question I want to ask from all my young friends' side and also from my side, Dr. Parolini and all the panelists, what they are using at the end of the surgery in all the three scenarios, VMTS, ERM, and LMH, what they're using at the end of the surgery.
What
as a
tamponade?
tamponade.
Ah,
Yes.
okay. Personally, I use
saline. Are you keeping it under
I
the
use
saline?
no, I use air.
Saline.
In my
Okay.
experience is this, I use air in epiretinal membrane and epiretinal membrane, epiretinal foveoschisis, I think it's the same thing. It's epiretinal traction, okay? I don't think we need to tamponade for a long time, so I inject air mostly to modulate the sclerotomies and in order to close very well the sclerotomies. That's it. I don't think we need a tamponade, and it's been described by Sengul and a large study that tamponade does not make any difference. Instead, I do recommend to use gas, although short-term gas. I only have SF6 in my operating room for lamellar macular holes because there is always a risk to lose the patch. You have to to lose the flap. We are dealing with the flap with tissue that has to stuff inside. So I recommend to have at least 3 days face down, only with the aim to keep the flap in the hole. That's safer to avoid the iatrogenic hole. In all the other cases, we don't need the long-term tamponade. So I think that air is more than enough, or just saline. I use air, I repeat, not for the macula, but to seal the sclerotomies.
Exactly.
That means in all VMTS and ERM air, and in the case of the LMH, you will use the SF6.
Exactly.
Lalit sir, what's your take?
100% agree with Barbara that even though I don't want to use, in patients of VMT and ERM, I would prefer to use saline, but air is injected primarily because I don't want it to enter fluid primarily for sclerotomy areas, but for macular hole as well as LMH, I'm not a very keen surgeon to operate lamellar macular holes, but whensoever I've operated, I have used short-term gas. But ERM and VMT only air.
If you allow me, I want to specify that in VMT, there are different grades of VMT. So if you have a preoperative stage, which is nearly a full thickness macular hole, then I consider that like a full thickness macular hole. So I would use gas as a precautious to be more cautious, okay? But if it's low grade, no. And also about the timing, compared to what Shobhit was saying, I tended to wait a lot before going to surgery. Now, if I see that the patient is going down with vision in epiretinal membrane, I advise surgery. And also in lamellar macular hole, I don't want to see a foveal disruption because I already know that even with surgery, the patient will not gain a good vision. So we should use the embedding technique and operate at an earlier stage to preserve anatomy and function. That's my feeling. So the patient where I wait more are the VMT because because of the higher chance of spontaneous resolution. I hope I was clear.
Can I
Shobhit
just,
sir, what?
yeah, I just want to add one point and also have Barbara's and Lalit's opinion, because Lalit is aware that in epiretinal membrane cases with large, heavy increase in the foveal thickness, after peeling, I had been using for a long time Ozurdex implants to, speed up the. Does it have any logic? I have found it beneficial and have used it in the past in quite a few idiopathic ERM cases, and especially the category which Barbara pointed out with the foveal tissue herniation. That is also another category where after peeling, I use Ozurdex, any dexamethasone implants. I just want their opinion. Is this the correct direction to take, or is it really of no use, what I'm doing?
Professor Lalit.
So I too have also used in a couple of patients because I believe that the restoration of anatomy may be more complete with this. It's a purely intuitive thing, not based on any data, long-term data, but I've used it at least 4 or 5, and I may be using it more often also, because it was like Shobhit was saying, it's more intuitive and looks more logical that see post-operative inflammation is better controlled in these eyes, and since these eyes have thick retinas, so we want more restoration of anatomy. But believe me, it has to be backed up by data before.
I don't have this experience. I have never done that. I use the Ozurdex only in cases of cystoid macular edema, post-operative cystoid macular edema, like Irving-Gass syndrome that I actually have also published after epiretinal membrane peeling with or without cataract combined. And so I don't have the experience of simultaneous Ozurdex injection. It could be a good idea. I'm not saying the opposite. I think it would justify a study of a comparison. So you have the power of numbers. We should do studies together. I'm willing to participate in any of them.
Barbara, I think I already have a huge data on it. Must have done nearly 50 to 300 cases if I count over the years.
Good.
Yeah. And I've been asking my fellows that we should take out, but then we need case control where we have not done.
Okay.
Dr. Ganesh? Dr.
Yeah,
Ganesh,
Dr. Barbara,
please
an excellent talk on BMTS. I wanted to ask Dr. Barbara, where would you avoid doing a surgery? Seeing the anatomy, the OCT, where will you avoid it? Say in a diabetic, how is the prognosis of a ERM, a vascularized ERM in such situation? And additionally, what we should look at so that we don't harm rather than do better for the patient.
So the question is when to avoid the surgery. Well, I think I always stop surgery when there is associated glaucoma, because I think that if we go inside, we have a high chance to lower the to decrease the optic fibers loss, to have optic fiber loss. So that's the contraindication for me. But in all the other cases, I actually don't exclude the surgery. Do you have a specific case in mind?
Vascularization around the ERM?
Vascularization. So that's not primary epiretinal membrane. We are speaking about a different topic like diabetes or that opens another topic. I would peel if there is a good vascularization of the fovea in angio-CT, and if I think that the contraction of the epiretinal membrane is significant on vision, I would still operate. I don't think it's a contraindication. If there is a huge ischemia, then probably peeling is of no use. So I'm not sure. I hope I'm answering your question, because this is a different topic related to diabetes.
Dr. Vivek and Dr. Shobhit, can you give your take on this?
Yeah, Dr. Dhawan, I had one point regarding the previous discussion quickly, where I think Dr. Chawla mentioned about Ozurdex. So my senior colleague here, Dr. Raja Narayanan, has just completed a thesis for a postgrad student, where I think he had randomized epiretinal membranes for just a surgical removal against surgical removal with on-table intravitreal Ozurdex injection. While I am not absolutely clear about the inclusion criteria, so there was some macular edema cutoff that was taken as inclusion, but my rough observation has been that there has been a quicker resolution of the macular edema, which is intuitive because the Ozurdex was used, and there was a relatively better vision improvement. But I think the overall recruitment, because it was as a thesis, so the time was limited, I think the overall recruitment did not allow for a statistically significant difference to be shown. But there was a suggestion as if using Ozurdex along with epiretinal membranes for a certain level of macular edema may have some value to add upon just a surgical removal.
Dr. Shobhit Chawla sir, Dr. Lalit sir, on the clinical characteristics which suggest that we should not operate this.
Yeah, Kaushik, I see. We should remember that we are treating OCT. We are primarily treating a human eye. So therefore, what Dr. Pillai was, hinting, when we should not operate is when patient does not want it, or patient visual acuity is good. In fact, I congratulate Dr. Barbara for operating a fellow VR colleague with 20/20 vision. But a very big part is that patient was the doctor colleague was disturbed with metamorphopsia. So for me, metamorphopsia is more ominous indication for operating rather than visual acuity. So in any case, all the Dr. Pillai, whensoever we tend to operate primarily because of multiple reasons, which patient, as I said in the beginning, that patient has to beg for surgery, that he is disturbed because of whatever OCT anomalies we have. Otherwise, I am not a very thing that I will motivate the patient to get operated. Patient has to ask for it, whether it's ERM or whether it is vascularized, non-vascularized. Those things can be taken care of. Like primary ERM is never vascularized, but secondary ERM, because of inflammatory or vascular disorders, tend to get vascularized. So even then, if patient vision is compromised or if symptoms are there, we still go ahead to operate. Dr. Barbara, you laid down indications for ERM and VMTs, but for lamellar macular holes, indication for surgery, when to intervene. Except that I know if during a vertical follow-up of my own patient, I've seen, and the things are getting worsened, I may. But do you have any specific criteria that which patients of LMH should be taken up?
In the end, I think the criteria are the same, because when they tend to lose vision and they start reaching 0.7 and 0.6, and I see the fovea is worsening even under an anatomical point of view, now that I use the embedding technique, I tend to to go for surgery sooner than what I used to. I'm not more afraid of inducing a full thickness macular hole. And I know that if I wait too much, the photoreceptors will, I will lose photoreceptors, they will detach, and I will not be able to restore the outer retina even after surgery. So ideally, we should intervene before that stage.
Dr. Parolini, it's very easy to take up the surgery in the tractional ERM type of cases, but degenerative, I think it's a very dicey type of cases.
It's not easy, but it's totally doable. Once you start a few cases, when you do the first one, I still remember it. Really, I was having the feeling I was peeling the fovea itself. It's so yellow, fluffy, and difficult to grasp. But then you get used to it, and you get the feeling of it. You see the tissue itself, and then you stain and you find the ILM on the bottom of it. So you know you are epiretinal. So you leave it all around it's totally doable. Believe me, it's easier to do than to say.
Dr. Kaushik, any other question from the audience side?
My one question to the panelist is like, what is your approach to patients with glaucoma and epiretinal membrane, like advanced glaucoma and epiretinal membrane, and patient is complaining of visual decline?
If the patient has severe glaucoma, I do not operate.
Yeah, because possibility of making the matters worse may be there.
Yeah, I would agree, because I think a lot of these cases with severe glaucoma, we have to understand, just like trabeculectomy, if you operate a trab in a severe glaucoma, you risk losing whatever is left to hypotony. Similarly, VR surgeries can have pressure fluctuations, especially when we are closing the case, when ports are being removed. Howsoever we may try, there is a possibility of hypotony coming in. And actually, we've had an experience of one patient where the vision had got lost. Patient had background glaucoma, also had ERM. ERM seemed on OCT to be thick. Patient was complaining of vision loss. It was very difficult to differentiate whether it was the glaucoma which was progressing, which was already advanced, or it was the epiretinal membrane which was causing vision loss. It was a catch-22 situation. The patient was operated, and the final consensus among the retina and the glaucoma team was that possibly it was something like a wipeout, which took out the vision. So I think, yeah, very difficult situation, but one has to tread very cautiously. And I think it's better to err on the side of not operating such cases.
I agree.
We have a query in the chat box. Like, what are the non-surgical options for ERM with macular edema? Anti-VEGF with posterior subretinal tricot or intravitreal Olpidem?
Postoperative CME. We can use.
Epiretinal membrane with macular edema.
Yeah. I think it's reasonable to inject steroids and decrease the edema. It's good for two reasons. First of all, you see what vision can reach the patient without the edema, so you have a better idea of whether it should be peeled or not peeled. And then, even if you have to peel, it preparates the fovea for surgery, because it's much better to peel a membrane without the edema than with, so you don't risk to unroof the fovea itself. So it makes, I usually do that. I start with the Pred Forte, just drops, because sometimes it's more than enough. And if it's not enough, I try injection of steroids.
I have had good experience of using the posterior subtenon injection also in such patients, because ERM may be, inconsequential also in such lot of these. So I have had good experience of using posterior subtenon injection also. So I agree with I think Vivek, what he was trying to ask in contrast to going inside.
Dr.
Dr.
Atul.
Kaushik,
Yes.
any other question
No,
from audience side?
we do not have any other questions from audience side. I think this was a very excellent discussion, and we learned so many new things here. And we thank our esteemed panelists for joining us. And we have our session 4 will be on optic speed on 19th November 2022. Next one by Dr. Zofia, who has done multiple works on optic speed macular. We'll invite you all to that online learn from the master's class, and closing comments from Dr. Atul.
Thank you, Dr. Parolini. Thank you, Dr. Parolini, for just an amazing talk. As I have already told that this is one of the best talk I have listened in my whole medical career. And thank you very much, Lalit sir, from joining from a totally different time zone from Brisbane, 1 o'clock in the morning. And thank you, Shobhit sir and Dr. Vivek, for giving your time for this international masterclass. Thank you very much. And in the last, as Dr. Kaushik told, we want to see you in our next international masterclass on 19th on optic disc pit with maculopathy by Dr. Zofia Nauroka. And we are going to close the session. Thanks a lot.
And I'll thank Dr. Ganesh and Dr. Maya for their support in the academic cell. And thanks, Dr. Atul, for making this possible. You are the man behind this show. And we are actually privileged to have Dr. Barbara Parolini here. Thank you, ma'am, for your time. Thank you. Have a good night.
Thank you. Thank you, everybody.
Thank you, everyone. Thank you. Bye-bye.
Bye.
Bye. Thank you.
Thank you.
enough.
Thank you for hosting me. Thanks.